So I'm not an ophthalmologist, full disclosure there, but I always start with whatever symptoms you're having, right? That's a really good place to start, and let those ophthalmologists know that you have a connective tissue disorder, or you have a very high suspicion for a connective tissue disorder if you haven't been formally diagnosed. When it comes to looking for papilledema, of course, what we're looking for is increased intracranial pressure, right? That's a sign that there's increased pressure there. So it goes back to our neuroanatomical issues that we touched on. And certainly that's an important screening that you would want to do when you are getting evaluated. But there's other issues associated with hypermobility as well. Not all versions of hypermobile EDS have the same kind of ophthalmological issues as we might see with other single gene mutations that cause connective tissue disorders, but there are cases where there is dislocation of the lens of the eye, or kind of other visual disturbances as a result of those connective tissue issues. So certainly just making that ophthalmologist aware of what your risk factors are, and also touching on anything that you think could be an active symptom or that's been changing with your vision is a good place to start. I would say the answer is most likely no in most cases. So a rheumatoid factor is an IgM, immunoglobulin antibody against IgGs, and we don't necessarily see huge increases in IgG antibodies with mast cell activation like we would with certain rheumatological conditions or with certain chronic infections. So things that cause high rheumatoid factor tend to be things like rheumatoid arthritis or hepatitis C. Sometimes you'll see it with the lupus connective tissue disease-related conditions, but really not something that I've noticed with mast cell without those conditions also being concurrent. That's a complicated question. I think anything foreign that you put into your body, whether that be taken in orally, whether it be an infusion or a subcutaneous injection, can exacerbate mast cell activation. But immune modulators are not necessarily any more likely to be the cause of that than any other thing that you put into your body, like a strawberry or vitamin D supplement necessarily. That being said, these immune modulators do increase your risk for infection. And if you were to have a chronic smoldering infection, that certainly can exacerbate your mast cell activation as well. So if you see mast cell getting worse, you have to kind of ask yourself, am I reacting to the medicine? Do I have a infection that's kind of chronic and smoldering in the background that's not going away, that maybe I need to go off of this medication for a while so that I can clear that infection? Those would be considerations in those cases. Yes, it absolutely can be a mast cell reaction, but there is a differential diagnosis in those circumstances. Whenever somebody comes in with extreme itchiness and they don't have a visible rash, I am generally, at least in this population, I am generally vacillating between mast cell activation and small fiber polyneuropathy or other versions of nerve damage. So you can have a neuropathic itching. So it's really the way the signaling of the nerves is being processed that creates the itching, or you can actually have histamine-based itching. Sometimes it's not difficult, if you tolerate it, to just take some Benadryl or diphenhydramine in high doses, knowing that it might make you sleepy, but as a diagnostic measure, right? And if the itching gets better with the Benadryl, it's probably histamine-based, it's probably mast cell-based. If it doesn't, you may want to talk to your treating provider about considering neuropathic pain medicines, even on a diagnostic basis. Hey, can I try some gabapentin or some Lyrica 1 or 2 times and see if that helps my itching?
Hi, Dr. Yellman. I have severe MCAS and hypermobile EDS, and my question is, I've been told to avoid NSAIDs, but I have severe inflammation in my body. Is there any recommendations other than icing to deal with inflammation?
Sure. So inflammation is a very broad topic, right? The word inflammation to me is sort of a pet peeve of mine as a rheumatologist, because it can mean neuroinflammation, and even with neuroinflammation, it can mean release of mediators from microglial cells in the brain versus white blood cells getting into the cerebrospinal fluid. It goes in its own direction. But as far as non-steroidal anti-inflammatories, that's sort of a general recommendation in HEDS. There are, of course, many people with mast cell activation or other GI issues. We see dysmotility as part of the dysautonomia. And so that can make you more likely to experience the complications that NSAIDs are known for in the general population, right? Ulcers or other bleeding in the GI tract in particular. So it is sort of general best practice to not use NSAIDs if you don't need them. And that's easier said than done, because with the hypermobility, with the joint issues with some of the neuropathic pain, if NSAIDs are really helpful, they can make a big difference in your quality of life. And so I certainly don't like to deal in extremes or specific rules. And I think it's not unreasonable to consider certain NSAIDs like celecoxib, which is a little easier on the GI tract, or meloxicam, when tolerated with close monitoring and a provider involved. That being said, so those are anti-inflammatory in some ways, but they don't address all kinds of inflammation. And so if there's other issues with inflammation, perhaps you have to control your mast cell activation better. Easier said than done again, but part of the recipe here. And you want to be sure that there's not some other sort of, if you will, autoimmune inflammatory disease or like a celiac disease or something else going on. So you want to be looking for other sources and other treatments. Another thing that I would say that I think has gotten lost in medicine for a long time, and this is something that I bring from my rheumatology experience, acetaminophen or paracetamol, Tylenol, it's a really good drug. It's not technically anti-inflammatory, but when it comes to musculoskeletal complaints, we underdose Tylenol so much because we're worried about the toxicity over 4 grams. But honestly, you can take 1 gram twice a day. People who have cirrhosis can take 1 gram twice a day and still get really good pain relief in lieu of using nonsteroidal anti-inflammatories. So we kind of worry about overdosing on the Tylenol, but really 4 grams is where we start to worry. And if you can get by with symptom management with 2 grams for long-standing periods of time, I think that's much safer. And if it's effective, I would go for that first.
Yeah, that's the route I've been going. I've had anaphylactic reactions to the anti-inflammatories that you mentioned. So, okay, thank you.
It depends on the perspective we want to look at it. I still think of it as a connective tissue disorder that predisposes to neuromuscular disorders is sort of how I categorize it in my head, but I'm certain other providers might see it slightly differently. And as we continue to learn more about the various hypermobile spectrum disorders, I think we will adapt and update those classifications. But certainly neuromuscular complications are a major area of clinical symptomatology, in an area that we as clinicians should be focusing on in order to help people, because we can't change the underlying genetics. We certainly can sometimes address the neuromuscular complaints. So I have had a couple patients undergo prolotherapy, and I think we're talking about specifically for craniocervical instability or atlantoaxial instability in this case. And I think the jury's out on prolotherapy. And what do I mean by that? Well, my patients, I have some bias in my patients in so much as they were probably particularly ill when they went in for prolotherapy to begin with, and so they didn't have really any clinical response. But there's certainly plenty of accounts online and from other patients with hypermobile spectrum disorders where they found prolotherapy to be helpful in their particular case. And so it sort of begs the question, where were they in the course of their illness? Were they on the path to more aggressive CCI, but not having severe manifestations? And if you intervene earlier rather than later, does it make a difference, et cetera? I think those are questions we need to answer as we move forward in medicine, but the answers are not there right now. And the people who perform prolotherapy that I'm aware of are very proprietary about it. These are not, they have data, but it's not really peer-reviewed data, and they don't share their populations and why they choose to do it in certain patients, et cetera. So I have a lot of concerns about that. And I think there is probably, among all of us, there are some patients who would be great candidates for it, and there may be some niche where it's helpful, but we don't know what that is. And there's certainly people that it doesn't help. So I'm a little leery on it right now, but it doesn't mean that I wouldn't be open to learning more if we start actually doing peer-reviewed research on it. I get this question almost every day, and I don't have a good answer for you right now. This is frontier medicine, to be honest, and I hate to say that. It's very, very important for this population, but we are not there yet. I was lucky enough that there's a Spanish neurosurgical specialist who I have worked with closely in the past, and one of his assistants was actually in Salt Lake City, where I practice, and helped us get a particularly small imaging center to update their protocols so that the imaging would be more likely to be helpful. And even then, we don't quite have everything that we would desire, like an upright MRI, for example. But we do see that with very specific training of very specific techs and a lot of effort being put into managing the exact positioning of the head and neck for this imaging, and then going back and adjusting it just a millimeter and running back into the room again. If you do that over and over, you do get a much better image that's way more helpful to the few neurosurgeons out there who do this. So it's an extreme challenge to get access to that right now. And not only that, but there just are not enough neurosurgeons who are doing this. So I'd love to say there's an easy pathway for this. But at the moment, there just isn't. We are still kind of advocating for people to understand the field and start incorporating these protocols into their work, and to start getting more neurosurgeons on board. As I stated in my lecture there, most neurosurgeons that you would talk to at really good institutions do not understand CCI or AAI at all, and they almost don't believe in it. So we've got to start there first. I'm not quite sure in this case what kind of inflammation we're referring to, but certainly I think when people refer to inflammation, they're discussing symptoms of discomfort in the gut, dyspepsia, for example. So what I tend to do in our hypermobile population is I want to make sure there's no H. pylori infection. I want to make sure there's no celiac disease. I want to make sure there's no inflammatory bowel disease. I want to make sure there's no non-steroidal induced peptic ulcer disease, as we talked about with Tammy's question. And then I start looking at things like mast cell activation, and can I control that better and have a more focused approach to keeping that minimal. Is what's the motility of the gut? Are we underestimating or not recognizing GI dysmotility, especially in the upper GI system, the gastric area, the first portion of the small bowel? Is there SIBO, small intestinal bacterial overgrowth, and do we need to treat that as well? And then if there's still pain and discomfort, I start thinking about some of our vascular complications. So things like median arcuate ligament syndrome or MALS. I start thinking about May Turner's. I think about Nutcracker. There's a high incidence of endometriosis as well. And depending on where and how the gastrointestinal symptoms are presenting, if they're more lower GI, you certainly have to think about endometriosis complications. So I kind of run through those as being common complications and look a little deeper to see what could be driving symptoms and try to focus in on those when I have patients in front of me like that.